Borda. For those of you who don't know, that's good morning in Welsh. It's funny how the two speakers have managed to give me just the right amount of time that I was originally given, so we won't hang around. I'm just going to give you a little overview of the Scottish Service. I have no conflict of interest. I had lots of conflicts of interest yesterday, but now that the Six Nations is over, I'm relaxed. We commenced our national service on the 1st of October 2016, following a bid to what we call national services, which is the highly specialised services in Scotland. And it got accepted, I think, on the basis that it was cheap and it was low-hanging fruit, and they gave it to us and they thought it wasn't going to cost too much. It's based at the Children's Hospital in Glasgow, and it applies to children and adolescents, not adults. And so our principle is that we provide a comprehensive service, and Ian has alluded to the conservative management, which we think is very important. And that's sort of what got me into the business in the first place, seeing a lot of patients in clinic who I was going, oh, it's a carinatum, but it's not very severe. I'm not going to operate on it. What am I offering? And the answer was I wasn't offering them anything, so I needed to do something. And obviously, our surgery is nurses primarily in the children. We run a clinic on a Wednesday morning. We have orthosists, we have medical illustration, we have physio, and in the afternoon the physios and the orthotics run a clinic of their own, and they keep track of things. I say there's 1 to 2 of 3 surgeons on the rota. More recently it's just me. Nobody else turns up if I turn up. These are our new patient referrals over the years. And you can see where there's been a big jump since we became a national service, and we basically opened it up to the country as best we could. A big drop with COVID, as you could imagine, and then a pretty big rebound in 22, but it looks like we're heading towards about 250, 260 new patients every year with pectus defects. As surgeons, people tend to just think about excavatum, and if you read the literature, a lot of pectus literature is just excavatum. But of course, that's not the case, as Ian has alluded to. So in our practice, only 40% is pectus excavatum. 48%, or almost half the patients, are carinatum. What I call complex would be what Ian would call mixed defects. The odd arcuatum, and then some other referrals that come into us. So in our sort of sex breakdown, we have 85% overall are male. Pretty much the same excavatum, carinatum, a little bit less for arcuatum, but the numbers are relatively small. Interestingly, other defects, much less male preponderance. When we did our first had seen our first 1,000 patients, I looked at a few other issues. One was assessment of severity, and I'll be the first to admit this is a completely subjective assessment. So it went very mild, mild to moderate, etc. You can see it. And not everybody would agree. I'd go mild to moderate, and somebody go, oh, it's only mild, or it's moderate, or whatever. But here you can see that there's a shift to the more severe in the excavatum versus the carinatum, and I think that's probably an experience most people would see. And equally interesting, I thought, was with regard to being symmetrical. Now, if you go look at CTs and stuff, something that might be classed as symmetrical probably won't be completely symmetrical, but mostly symmetrical was quite a high percentage in the excavatums, but much, much less so in the carinatums, only 34%. And if it was asymmetrical, it interestingly tended to be about a 2-to-1 right to left. That was just our experience. When we did look at that 1,000 patients, we found scoliosis in 6.6%. Interestingly, again, higher, double the incidence of scoliosis in the excavatum than the carinatum. A lower family history, and that may reflect the fact that we didn't ask well enough. And again, a double the history of family thing. Again, not like Ian's data, twice versus excavatum versus carinatum. We found Marfan's in 1%. And I'll be the first to admit I'm the worst person trying to diagnose a Marfan's. But interestingly, very like Ian's data, we found an average BMI of 17.2. So having spent most of my pediatric surgical career looking after newborns, I end up looking now after guys who are taller than me and a lot skinnier than me too. We have a population of 5.5 million in Scotland. That's 10% of the English population, and knowing that I'm in Wales, it's 8% of the UK population. So we would be equivalent to about 3,000 new patients being referred to units. Now, not just for severe excavatum, this is right across the pectus spectrum. We have 70% of our patients, again going back to what Ian was talking about, are in the 12 to 16, that 5 years. There's 60,000 in Scotland in each of those years in the census. And if we look at that, we're looking at about one, this is my maths, so if there's a statistician here, ignore it. But I reckon there's about 1 in 1,000 for boys, the incidence, and 1 in 5,500 for girls for our data. This is peculiar to Scotland. This is all our health boards. Greater Glasgow and Clyde is huge by comparison with the rest of the country, but we are under a lot of pressure from NSD to be egalitarian. It's the buzzword in Scotland. Scots love being egalitarian. Usually it means chopping poppies down to be as low as possible, but in this case, you can see that we've dropped our percentage of referrals from GGC right down to 32%, where they had been almost at 60% at one stage. And since Malcolm's here, Lothian, who used to send us absolutely no patients, have now come up to 12.7 after we gave them a few talks and encouraged them. What do we do for excavatum in relation to prep for surgery? We get some clinical photos. We're very interested in 3D photos of the chest, where we can, I'm hoping we can start doing some measurements of the actual excavatum and carinatums to try and assess severity. We do the cardiopulmonary exercise testing, cardiology review, echo. I personally am very keen on cardiac MRIs, even though I have a constant fight trying to get them. We get clinical psychology as appropriate, as you could imagine. And interestingly, we do a thing called chest wall school. So anybody being prepped for surgery, we used to do it face-to-face, but now we do it online, where we get the surgeon, the anesthetist, the physio, the nurses, the pain team, and a family who've been through surgery before to come online and talk to them. Now, I don't go through the gory details of the surgery, but it's really quite interesting. So we tell them what's going to happen to them, but we also tell them what we expect of them, of the patients. And they find that when they come into surgery, for surgery, they're much more prepared for what's going to happen, which is really important when you're talking about teenage boys for the most part. Looking at the CPET stuff, we find that there's a reduced aerobic capacity in about half the patients. If you think about it, we're doing surgery at 15 or something. We then have the bars in for 3 years. And if we do a CPET at 19 or 20, they're completely different people from when they were at 15, you know, both physically and emotionally. So it's a very, very difficult group. I think in adults, it's probably easier to compare in a 25-year-old versus a 30-year-old. You're pretty similar. And I must say, COVID has completely screwed this up, because you've got a whole population of kids now who have dropped out of sport, gone gaming, and have never come back into sport again. They've stayed gaming, which is very sort of seductive lifestyle, as you can imagine. So we see that a big impact on our CPETs is the sedentary lifestyle. Here's Paul Burns, our CPET expert, with Donald Nuss. Paul's very proud of that. And he's tall, but he's not that tall, but Donald is very small. So I wasn't quite sure of the audience. I might be teaching people how to suck eggs, but I'm going to do it anyway. Obviously, when we go for our surgery for our NUS, we pop a template on first that gives us a handle on what shape we're going to do it. We're very keen on direct vision where possible. We don't tend to use the crane. Worst case scenario, I make a sub-ziffy and put a big Langham back in and lift it, and I get that job and somebody else does the rest. I do appreciate that in older patients, the crane may be very valuable. There's our two introducers in situ. We tend to put 2 bars in for everybody. And there's some of our post-ops. Carnatum and arcuatum, we do the ravage. I'll show you. I'd like to make a mention of the Strata system in case anybody's tempted to use it. Please don't. It's crap. I hate to say that, but you can see there, we did 5 patients. It looked absolutely smashing at the end. And if you look, both of the systems have snapped. All 5 of my patients snapped because, of course, they just got bigger, and these things are pretty small. And it scares the crap out of me that some people are still advocating this for excavatum. So it's one thing having a broken piece of titanium knife sitting outside your sternum, but the idea of it sitting behind your sternum just sort of scares me. So we tend to use the Sternalock Blue now for this. Again, we've got a 5.5 million population, so by definition our number, and we're children only, so our numbers are going to be relatively small. But you can see here, for this year coming, we have 24 NUSs lined up. We've done 1. It is a summer operation. The vast majority of our patients, it's after they finish school, so we have to crush them all into that period of time. And I can tell you waiting lists in pediatric surgery are terrible. Ian has talked a ton, and I'm not going to go into it, about the pectus posture. This is probably one of the least bad ones, but it's still got a bit of it. He's talked about the vacuum. As Ian says, under 2.5 centimeters or preferably less. I absolutely agree with him. The younger, the better, within reason. If you get really young kids, their skin doesn't cope with it very well. Flexibility is everything. I'm real interested in sleeping in it because we kind of go with 2 to 3 hours a day. And I agree with you, a duration about 12 months, maybe a little longer sometimes. There's somebody who you can see had one. Arguably, I would think probably they were a bit generous using the bell in this kid, but he got better, but not perfect. Bracing. This is kind of what got me into this in the first place. I wasn't offering patients much of a thing, so I spoke to our orthotics department, and one of the orthosists had just come back she was a professional footballer in the States and then had worked in Dublin and was bored by that, so she came across to Glasgow, which was her hometown, and she just happened to arrive as I went to talk to them, and this has moved along so that we make our own brace, and it costs 100 and something quid. That's all, okay? And it's worn like that. It's very low. You hold it, and it's made out of carbon fiber. So even when you go to pick it up, you think it's going to weigh such and such. It weighs next to nothing. You can hardly feel it. So it must be correctable. We now have I'm going to say a tensiometer. It measures in newtons. So we lock the door, push the kid up against the door, and correct the pectus up against the door. And if you're under sort of 80 to 90 newtons to correct, we can probably correct it. If you're over 100, you can forget it. It's just a waste of time. And we like them around 60 or 70. And obviously, if you can get them younger, most of them are that. Our sort of program is to wear them 16 to 20 hours a day. That's what we encourage the kids to do. And obviously then, once it's corrected, as Ian is saying, hit it hard early on, and then you can relax back to a less severe arrangement. And Donna's done a lot of work, and this must be patient-driven. Very often it's parent-driven, not patient-driven. If it's parent-driven, you're wasting your time because they're not the ones wearing it. And you can see there it's just not so severe. You can see here, patient choice, lots of resolved. And if your hours are low, chances are you're not going to resolve this very well. We also do quite a bit of work, and it's interesting, some of the more sort of disease-focused questionnaires are useful. We just do a quality of life questionnaire, and you can see here that these kids, by and large, tend to have low scores. This is one of our patients. I was going to ask Kate, could she Photoshop the bar a little lower on his chest, but I kind of figure she wasn't taking calls on those kind of things at the moment. So our service aims to provide a comprehensive service for all pectus abnormalities. So even you come in with rib flare, buckled ribs. Is this a tumor? God help me. We offer non-surgical treatments where suitable to minimize the overall requirements for surgery. And in that earlier graph, you'll see how few ravages we do. And we acknowledge both the physical and psychological, psychosocial effects of the chest wall deformity. So we look for the right option for the right patient. Thank you for listening.